안녕하세요. 박종현 원장입니다.
Greetings, I'm Dr. Park Jong-hyun. This is the second anterior implant lecture. This is about aesthetic impression taking in the anterior region. I usually take implant level impression taking in the anterior region with the transfer impression coping. This is the product called transfer impression coping. Abutment selection, adjustment, and the final crowns are fabricated all together on a model. For a single tooth restoration, as I said in lecture 1, extraoral cementation is used. In using the screw hole, it is connected in the mouth. The prosthesis is much bigger than the healing abutment. The healing abutment is changed bit by bit, similar to the shape of the prosthesis. What is important is that it is very painful for the patient if it is connected like this. To connect in the anterior region, I use anesthesia. The final prosthesis is completed. One abutment is tried in. Actually, everything is connected extraorally to complete the prosthesis. After 4 years, both soft and hard tissues are stable. The interdental papilla over time has recovered quite a lot. Another case, at number 22, an implant was placed. Just like the previous case, implant level impression was taken and I work with the plaster model. I try to make the screw hole in the palatal side as much as possible, and it's connected in the mouth after extraoral cementation. What is important is that you can see whitish part in the gum because the implant prosthesis is bigger, the healing abutment, so we need to use anesthesia. Number 22 is hopeless, so that was extracted and an implant was placed. A custom abutment was used, but for aesthetic reason, a buccal side, it is made subgingiva. It is formed subgingiva, usually 1 millimeter or up to 2 millimeter subgingiva is used. So this is how the abutment was fabricated. If you look at here, the palatal side, I try to fabricate it above the gingiva. For a subgingiva margin case, abutment level impression is hard to take. In such cases, I use implant level impressions with the transfer impression copings.
임플란트 레벨 인상을 주로 활용하고 있고 그 도구로는 트랜스퍼 임프레션 코핑을 사용하고 있습니다. 다른 정리를 보겠습니다.
Another case, and this should be extracted, and an implant was placed like this. Here, a transfer impression coping is used, and this is a screw type prosthesis. As I said in the previous lecture, I no longer use casted abutment anymore, but I used it before, so this is the casted abutment. Using the abutment on the plaster model, screw type prosthesis was fabricated. Everything will be finished once the prosthesis fabricated in a lab is connected. If I explain why I do not use the abutment anymore, the connection part oxide film may develop, which needs to be removed. In the process, the connection part can be damaged by a lab, of course depending on their capability. But this can be used for upper anterior region. We restore 2 teeth. We use a similar protocol. 2 implants were placed in a position to have screw holes on the palatal side. The disadvantage of this is that on the labial side, the space is sufficient, but on the apex side, the residual bone is not sufficient. That can happen often, so rather than the residual bone on the apex side, the crestal bone, residual bone is much more important, so this is not a big issue. I try to place implants as palatally as possible, not in the direction of the root. I don't try to stretch the limit in terms of the implant diameters and length. I take the implant level impression just once, not many times, and abutment and the prosthesis are fabricated all at once like this, with screw holes on the palatal side as much as possible. As I said before, this is different from the single tooth restoration, which uses extraoral cementation and screw holes. In this multiple restoration, the misfit can happen in this area, making it hard to get passive fit. The key to internal implant is the connection. For proper connection, abutment should be connected first, followed by the cementation of prosthesis to get the passive fit. If this is extraorally cemented and connected with the screw, passive fit is hard to form in the connection area. For multiple restorations and to succeed with the stable prosthesis, we need to use a supramargin on the palatal side as much as possible. The subgingival margin should be 0.5 to 1 millimeter, not too deep, before cementation. As you saw before, the screws are removed using the screw holes to remove the cement. Even though we are very careful during cementation, subgingival margin cement removal is very difficult. If you can adjust the volume properly, it can be done, but after cementation, we find residual cement from time to time. Therefore, also in multiple cases, palatal screw hole positioning is very important. For a subgingival margin case, extraoral cement removal makes a difference in the outcome. Let's look at another case, which is from Austin Master Course textbook. After healing abutment is removed, the soft tissue like this, molded by the healing abutment, which is very different from the final prosthesis. So this is very different from the final prosthesis crown. In that case, we use a provisional crown, which molds the soft tissue, and the properly adjusted provisional tooth is copied. A transfer impression coping is made and impression is taken. I know it's best to take impressions after forming the soft tissue similar to the part of the final prosthesis that goes into the soft tissue. So this is how the soft tissue is stabilized and the final prosthesis is completed. We can get the most stable soft tissue form. However, I hardly use the method and I will explain it later. Abutment level impression taking. The impression taking is hard to use in the anterior region. Premolar and canine, which were mobile, were extracted and 2 implants were placed. The lip line, fortunately, is covering the margin area. If that is the case, we don't have to use a subgingival margin there. We need to take caution for visible part aesthetics. For an invisible part, health should be given higher priority than aesthetics. You can see it is a supragingival margin because of the smile line that is covering the area. After using provisional teeth, abutment level impression was taken. Final prosthesis was completed. Abutment level impression can give a very good margin fit because of supragingival margin. Now, subgingival margin, abutment level impression taking. Transfer impression coping is used at the beginning. Before connecting the prefabricated custom abutment in the mouth, scanned first using a model scanner. After the secondary surgery, soon the prefabricated abutment is connected and the temporary restoration was mounted. Also, for the provisional restoration, to take abutment level impression, before trying off the prosthesis, the margin fit should be good enough. With the temporary in the space, impression taking and the stabilization of prosthesis can be facilitated. Even with the abutment level impression taking, regrettably the margin is not visible. The subgingival margin could not be obtained with impression taking. With the trimming, the margin is not made clear. Before connecting it in the mouth, the abutment image can be merged. It is attached, merged. This way, the subgingival margin is easily obtained. Very good fitting subgingival margin is observed. I use PFM or PFZ prosthesis using ceramics much more than full zirconia, so I hardly use distal scanning. If lab technician can produce aesthetic prosthesis with a full zirconia, I believe distal approach can be a very good option. But for me, who use ceramic quite a lot, you can see ceramic here. Actually, the analog impression taking using a plasma model is a much more familiar option. 5 years later, adjacent teeth discolored. At the beginning, the shade did not match, but with the discoloration of the adjacent teeth, the color of prosthesis became much more harmonious. Maybe the lab technician considered the discoloration of the adjacent teeth in the future, so he made it darker at the beginning. So the prosthetic shade harmonious with adjacent teeth can become different after some time. In this case, I was fortunate to have harmonious result later. So the color modification would be very hard if we do not have the screw hole on the palatal side. So cementation type is the last option, but we need to be very careful in using it. Immediate placement and gap healing was performed. Inevitably, this tooth with post was extracted, and an implant was palatally placed and the gap was healed. A lab sent us this. This is the final prosthesis they sent us. Let me talk about the meaning of provisional tooth that is used to mold soft tissue, and individualized impression coping is used for impression taking. That is the ideal approach. Actually, for single tooth restoration, I don't do soft tissue molding with the provisional tooth, because the soft tissue molded by a provisional tooth will be remolded by the final prosthesis, so it is not very meaningful. So if ideal final prosthesis can be fabricated by a lab in the first place, actually provisional tooth is not really necessary to achieve good outcome in many cases. However, if you do not have the provisional process and send the impression taken with impression coping to a lab, the lab technician's opinion would be very much reflected in the final prosthesis. And I'm not sure about what problems it would bring, but this kind of very unexpected design came. I don't know what it really means. So I believe the provisional process is where a dentist can evaluate the form first before it is sent to a lab. So we need to use a provisional, so not too overly reliant on a lab. We need to take the provisional process. I refabricated the prosthesis with a screw tape, and it is connected and completed. 4 years later, it remains stable. Today, I talked about impression taking in the anterior region. Protocol. First, implant level impression should be taken, and the ideal form should be communicated to a lab. The final abutment and prosthesis need to be fabricated. If we have a provisional tooth, its information, including photo, need to be sent to a lab as much as possible. For a single restoration with a palatal screw hole, extraoral cementation is used. And for multiple restorations with a splinting, it is never cemented extraorally. Abutments are first connected, cemented, and the prosthesis is removed using the screw hole, and cement is removed to achieve passive fit in multiple cases. I usually use a screw type connection, so there is really not serious problem with this residual cement. I always use anesthesia because the soft tissue formed with the healing abutment is different from the form of final prosthesis. For extraoral cementation, unlike everyone else, I use ceramic much more than a full zirconia. So if you use ceramic, distal approach is not really easy to use, so I use the analog approach using plaster model. I use PFM and PFZ models quite a lot, but in the future I believe zirconia prosthesis, very beautiful aesthetic outcome is demonstrated by dentists, and I will learn from them, and I will cooperate with labs, and I will transform myself toward a digital. If you want more details, please come to the offline master course. This concludes today's lecture. Thank you very much.
저는 이만 물러가 보도록 하겠습니다.